Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, my colleagues, ladies and gentlemen. Today we are in continuation with the MS Update 2020 webinar, second day. I would like first to thank Dr. Suhail Rukin for his invitation for me to chair this session. Additionally, I would like to thank Novartis and MCO for organizing this day today. So we have today 3 presentations. We are starting with Dr. Suzanne Ibrahim. Suzanne is probably well known for all neurology community in United Arab Emirates and Gulf area. She is fellow of Royal College of Glasgow and Edinburgh, and she is consultant of neurology and associate professor of neurology at Sharjah University. She has special interest in multiple sclerosis. She is a specialist in multiple sclerosis, and she has a lot of, I think, research, and she authored and co-authored multiple papers and publications. Suzanne is going to talk today about fertility issues in multiple sclerosis. Please, Suzanne, it's your stage.
Thank you, Dr. Shakra.
So you have 25 minutes.
Assalamu alaikum wa rahmatullah. I would like to thank EMINS and the meeting organizers for giving me this opportunity. My talk will be on an unexplored aspect of multiple sclerosis. We will talk on fertility and is it truly an issue? I have no conflict of interest to disclose. Our talk objectives will cover impact of MS on fertility. What are the factors affecting fertility in MS? Does MS affect male fertility? And what about MS treatment and its effect on fertility? And what is the effect of fertility treatment on MS? Then we will summarize and conclude. So first we'll see MS impact on women's fertility. Many patients with MS are young women of childbearing age for whom pregnancy and the related issues is often a major concern, particularly now that we have immunomodulatory treatment that is successful and women with MS wish to lead a healthy life. The role of pregnancy in MS has been discussed for a long time and extensively, and there has been very less emphasis on the effect of MS on fertility. I found very few articles that specifically target this topic. The frequency of childlessness in MS female population might be higher than in general population, and this was suggested by a Swedish registry. This is a study we will see now. This might reflect the fact that patients with disability might choose to avoid or postpone pregnancy, mainly because of concern about taking care of their babies. And in other words, we could talk about elective nulliparity rather than an issue of lowered infertility. Some MS patients may also be concerned about the genetic risk of transmitting MS to their children. This is the Swedish study we just mentioned. It was presented as a poster at the 31st Congress of ECTRIMS in 2015 in Barcelona. The group studies around 3 million women in Sweden in 2010 between the ages of 20 and 64. Out of these, 10,000 women with MS. And the conclusion was women with MS had fewer pregnancies compared to women in general population. And they related this to reduced fertility or disease severity that impacted the decision of becoming pregnant, or interference of MS treatment with fertility and loss of partners. Sexual competence and peculiar endocrine patterns might be relevant in terms of fertility, especially in people with MS. However, for people with medical conditions, chronic medical conditions, fertility could be impaired either by health issues, including the effect of treatment, leading to reduced ability to conceive, or by social issues such as reduced opportunity to find a partner or a decision to avoid pregnancy because of the disease itself. In MS, it is very likely that social issues are important and could lead women with MS to have fewer pregnancies, even if their ability to conceive is normal. There are two terms that are interchangeably used whenever we talk about fertility. Fertility is the term that indicates the number of children that are produced or born, where fecundity means the ability to produce children. However, in common language, fertility is used to indicate the ability to become pregnant, and for the purposes of this discussion, we will use fertility in its common meaning of ability to become pregnant. And there have been some reports suggesting that the number of children that are born to women with MS is reduced, and we have other reports suggest that women with MS may have reduced ability to conceive, which means both fertility and fecundity are reduced in patients with MS. Now, how do we measure fertility in MS? Now, measuring fertility in MS is difficult. However, there are indirect methods to do this. One aspect of fertility is ovarian reserve. One study using transvaginal ultrasound to evaluate ovarian volume, follicle count, and ovarian artery Doppler found a low ovarian reserve in MS patients. The level of anti-Mullerian hormone, which is a peptide hormone that is considered to be a marker of ovarian reserve and related to the menstrual cycle, hormone levels were found to be low in young women with MS compared with controls, and this was suggested by Thorne and his team. While this is a small study, it provides evidence that women with MS may have reduced ovarian reserve and hence reduced fertility. Another means to measure fertility in MS is to measure sex hormones and gonadotropins. Abnormalities of the levels of sex hormones and gonadotropins of the type that are associated with reduced fertility have been reported in young women with MS. We have shown that MS affects female fertility. What about male fertility? Studies showed that onset of MS in men generally occurs when their testosterone levels tend to decline, and lower levels of testosterone have shown associated with higher disability. And this might be related to the anti-inflammatory effect of testosterone, which has been shown to play a neuroprotective role in both animals and in clinical studies. A recent study showed that men with MS have lower levels of endogenous testosterone, which is a potential marker of male infertility, and it has also been suggested that men with MS have poorer semen quality. However, birth outcomes of pregnancies fathered by MS men did not differ from healthy controls. What are the factors that affect fertility? There are many factors that are thought to play a role in affecting fertility both in men and women with MS. Of these, the major factor is sexual dysfunctions, which is often not disclosed by patients with MS, although sexual dysfunction have a negative impact on the quality of lives of these people. Recent studies show a variable incidence of sexual dysfunctions reaching up to 70% of patients. Reduced libido reported in majority both men and women with MS, as well as reduction in tactile sensations in more than half of these patients. Difficulty in achieving orgasms in 58%, vaginal dryness with consequent dyspareunia reported by a good percentage of women. Whereas in men, erectile dysfunction in 80%, reduced orgasmic capacity, which is the amount of semen that produced when a male reaches orgasm, is less than what would be a normal quantity in up to 64%. And they also reported ejaculatory dysfunction, and in both sexes, bladder and bowel incontinence, Weakness, catheters, visual defects, speech disturbance, and other problems may also affect sexual activity and interfering with intimate relationships. Another factor is endocrine pattern. In men with MS, we mentioned earlier they have reduced testosterone, which may potentially affect the sperm production as well as leading to sexual incompetence more than quality of semen. The role of endocrine pattern in women with MS is reflected on the central influences on the hypothalamus and the pituitary gland, which may lead to dysfunctions of the reproductive axis, clinically appearing as menstrual irregularity and infertility. Moreover, women with MS were shown to have significantly higher FSH, follicular stimulating hormones, and LH, luteinizing hormone levels, and significantly lower estrogen levels in the early follicular phase of their menstrual cycle. High FSH levels are considered a marker of reduced ovarian reserve, and a low ovarian reserve is strongly correlated to female infertility due to poor ova quality. Other studies reported a higher incidence of hyperprolactinemia and signs and symptoms of hypergonadoandrogenism, increased levels of male hormones, testosterone, free testosterone, higher incidence of greasy skin, acne, hirsutism were noted in a fashion very similar to that occurs in people with polycystic ovary syndrome. Other factors that can affect fertility in MS is presence of endometriosis, and MS is significantly more frequent in women with pelvic endometriosis, 7 times higher prevalence than in general populations or general females, as shown in American population. Endometriosis is a frequent disease characterized by presence of ectopic endometrial tissue in the abdominal cavity, often affecting the ovary, causing ovarian endometriomas or causing adhesions in the pelvis. And although it is a benign condition, endometriosis in a chronic form can considerably impact the fertility, especially in the advanced stages, where disruption of the pelvic anatomy may take place, compromising tube function. Even at the earlier stages and milder stages, endometriosis may negatively affect fertility by disturbing the intra-abdominal biochemical and immunological environment at the site where fertilization takes place. Now, looking at the impact of MS therapies on fertility. And this can be classified into 3 categories. We look at the symptomatic drugs and the drugs that are used for treatment of relapses, and on the disease-modifying therapies, which is immunomodulating and immunosuppressive drugs. Medications used as for symptomatic relief on MS. Anxiolytic drugs, benzodiazepines, and barbiturates may have a depressing effect on the sympathetic nervous system and may therefore interfere with ejaculation. Tricyclic antidepressants have an intact-stimulating effect on the sympathetic nervous system and can lead to sexual dysfunction in both men and women. SSRI antidepressant drugs may impair sexual function, and in fact, high serotonin blood levels may interfere with ejaculations in men and reduce libido and orgasmic capacity in women. Baclofen may also cause reduction of sexual competence. Drugs used for treatment of relapses, these are mainly represented by methylprednisolone used in short courses at high doses. This therapy may cause transient menstrual disorders, oligomenorrhea, and the use of steroids prior to pregnancy does not seem to adversely impact fertility. Steroids in high doses can inhibit hypothalamic pituitary gonadal axis in both men and women. Beta interferon causes alterations of ovarian reserve, but no sperm alterations. Glatiramer acetate lead to decrease of ovarian surface and number of antral follicles. Dimethyl fumarate, there is not known effect on fertility. Natalizumab, fertility alterations in female but not in male animals. For fingolimod, effects on fertility not well known and would have a protective effect on ovarian functions, at least in vitro. Metoxantrone leads to a deleterious effect on spermatocytes and ova, leading to fertility alterations in associations with other anti-cancer drugs. As for other newer medications used as DMDs, I could not find any articles that looked into the effect of these newer medications on the fertility in males or females. When we talk about measures to control fertility, we will talk about contraceptive devices and pills. There is limited knowledge about oral contraceptive use in MS patients. Counseling about contraception is usually provided by gynecologists or general practitioners rather than by neurologists. However, MS patients are treated for a long time with immune modulating drugs or immune suppressive drugs, and during treatment they are recommended to use contraceptives. And this implies in clinical practice that the use of oral contraceptives by MS patients is frequent, peaking up to 86%. Oral contraceptives do not seem to increase the risk of developing MS or to worsen the overall disease course. The short-term protective effect was attributed to estrogen modulating the immune response and protection of the neural tissue. Another positive consequences of oral contraceptives is that MS patients using oral contraceptives are less likely to experience menstrual-related worsening of MS signs and symptoms. On the other hand, the combined hormonal contraceptives should not be used for women with MS with prolonged immobility because of the concerns about possible DVTs. Alternative methods for birth control should be considered in these situations. Moreover, several drugs like barbiturates, carbamazepine, phenytoin, topiramate, and other drugs used for symptomatic treatment and complications of MS may interfere with the metabolism of oral contraceptives, leading to reduced efficacy. Oral contraceptives with high estrogen content should be used in these situations. In turn, oral contraceptives can interfere with metabolism of other drugs used in symptomatic relief in MS patients, such as steroids and tizanidine hydrochloride. Now, what is the effect of infertility treatment on MS activity? Women with MS with reduced ability to conceive might explore various infertility treatment options. Among the more common and somewhat effective infertility remedies employed are assisted reproductive technologies, ART, which include artificial actions such as in vitro fertilization. The subsequent superovulation is achieved by administering exogenous gonadotropins at high doses. And it has been shown recently that gonadotropin and agonists may favor MS relapses during the first 3 months following gonadotropin treatment in fertile MS patients. On the contrary, such a negative effect has not been observed using gonadotropin antagonists, which are therefore recommended as the first choice therapeutic options in MS patients seeking treatment for infertility. There are numerous studies have shown that ART worsens occurrence of MS, so the safety of these strategies in MS patients need to be evaluated. Therefore, the prevailing advice in the medical community is that MS patients consider alternative and natural forms of infertility treatment. There are many unanswered questions with regard to assisted reproductive technologies. It's not known how many women with MS needing fertility treatment are within the total number seeking pregnancy, how many women with MS do not respond at all to ovarian stimulation, and if ovarian stimulation is safe in MS patients is not known, and if there is any relationship between the severity of the neurological symptoms and fertility. Therefore, a whole multidisciplinary approach is needed to collect meaningful data on unmet questions such as fertility potential and ART safety in MS patients, to educate and empower women with knowledge about fertility and to ultimately give patients the top quality care they deserve. Moreover, fertility of males with MS, a topic less discussed, can also be evaluated within the same centers. So to conclude my talk, data concerning fertility in MS are still scarce, but female fertility could be lower than normal. Several endocrine and sexual disturbances potentially interfering with reproduction have been highlighted in MS patients of both sexes, and some of the medical treatments used in MS may have a detrimental effect on the sperms as well as on ova, leading to reduction in fertility. However, there is no known effect of the newer medications used for treatment as modifying therapy in MS patients. The current status of reproductive technology provides useful tools for the treatment of patients complaining of infertility. The safety of these strategies in MS patients need to be evaluated. With that, I would like to thank you for your attention.
Thank you very much, Suzanne, for this very informative and difficult, in fact, topic. It was very nice. It is very fruitful. I expect a lot of questions that you will get for this very nice presentation. Our next speaker is today, Dr. Islam Shusha. Dr. Islam is Assistant Professor of Neurology and Consultant of Neuroimmunology at McMaster University in Canada. He is a fellow in multiple sclerosis, and he carries another fellowship in neuromyelitis optica spectrum disorders. He's board certified, Saudi board certified, and Bahraini board certified in neurology. I think he will probably be a regular visitor to our community of neurology at the United Arab Emirates. Hopefully we'll see him very frequent. His topic today will be about highlights about ECTRIMS 2020. Dr. Islam, please, it's your stage.
Yes, hi, Dr. Shakra. Thank you very much for your kind introduction. And it's my pleasure today to be along with this elite group. I'm starting sharing my slides, just confirm back if it's there. Okay, perfect. It's very unfortunate that we are not meeting physically due to the COVID. However, I think the virtual meetings might be convenient for a lot of people. I see the number exceeding 600, which it's more than people that attended some of the sessions in the MS and the ECTRIMS of this year. So these are my disclosures. There are not a lot of topics had been disclosed this year in the ECTRIMS due to the COVID. However, I thought that we might highlight a couple of the studies or the initial studies that they presented, so we can learn from our clinical practice, daily practice, or we can get some ideas or new informations. The first thing that I will start with is the prodrome for MS from the Helen Trumlett in British Columbia. And the prodrome itself, it's not new term for the neurology disease. It had been described previously in the Alzheimer's disease as an example, for the non-motor symptoms for Parkinson's disease as well. But for multiple sclerosis, they screen more than 6,000 MS patients and they match it with the controls through the codes of the symptoms like fatigue, anemia, pain, sleep disorders. And what they found over 5 years prior to the first demyelinating event, that those 4 pillars or those 4 symptoms were very highly suggestive of a prodrome of MS compared to the controls of more than 30,000 health controller. As an examples, for the sleep itself, there were more than 3 folds for odds ratio compared to the health controls. And for fatigue, it was almost the same. Anemia was 1.5-fold higher than for people that developed MS for 5 years before the first demyelinating to the health control. And what was more interesting, that anemia was higher in males compared to females, which they have MS, and was more than 100% for males that they got MS compared to males in the healthy control that they didn't get. And the last one was the pain, with the different types of pain, including the trigeminal neuralgia, fibromyalgia. It was 2 folds with the odds ratio compared to the health population. The second topic is it's an INROADS study. It's the abbreviation for Investigational Research of a Study of ADS. And ADS 5102, it's an extended release form of amantadine. It's a known medication that used for Parkinson. It's FDA approved, used for the levodopa-induced dyskinesia. And as well as we use the regular form of it sometimes for fatigue for MS patients. But this medication have been studied now in the INROADS to work as a medication to help the walking and the impairment of the gait for MS patients. The difference between the extended release form and the normal form, as you see from the pharmacokinetic profile here, is that it's a night dose, so it's slowly released through the body and maintain the plateau till the morning and starts to fades off. It's not like the amantadine, so we avoid the side effects all over the night and all over the day at the same time. It's a 3-arm study including the placebo and the small dose and the higher dose. And they included people up to EDSS of 6.5, as well as up to age of 70. And using prior amantadine or even fampridine was not one of the exclusion criteria. However, you need to be stable in the medication at least for 1 month. So the goal for the medication or the target, the primary point is that increasing of 20% in walking speed with a T25 feet step all over 12 weeks after the screening placebo. So as you see from this diagram that it was the higher dose showed statistically significant compared to the placebo, but was not the situation with the small dose. For side effects, the profile didn't differ from the regular amantadine dosage. However, that with higher percentage, which is expected for the dry mouth, the insomnia, the hallucination, and the constipation. What's very interesting in that study that even they did a subgroup analysis, they compared people that they were on fampridine and they add the amantadine, comparing to those they were start only the amantadine, and there was no any statistically significance between both groups. This means adding it to the fampridine is not really useful. Maybe it will harm the patient, adding more side effects. So I'm not sure if you know this doctor. He's a neuro-ophthalmologist. This is Dr. Yutof. He's the one who described the Yutof phenomena, which is the worsening of the MS symptoms with the exposure to the heat, including the shower, the humidity, or the hot weather. Couple of years ago, there is a study had been published using the aspirin as an effective pre-treatment for exercise for MS patients. So it was a double-blinded study. And we know that exercise is very important for MS patients, even to compete the fatigue. And this is very surprising for a lot of MS patients when they come and complain of fatigue. And then we tell them that exercise is the most effective modality to compete the fatigue, and it fits every patient according to his capability. However, they face an issue with the exercise that their body temperature got higher, and at the same time, they suffer from the Yutof phenomena, getting worsening of some of the MS symptoms. So adding the aspirin itself showed a statistically significant lowering the body temperature and at the same time increase the time to get exhaustion if we take the aspirin an hour before the exercise and then they do the exercise that it fits them. So what is the ASPIRE? ASPIRE is a double-blinded study, 3 arms, that they will add the acetaminophen besides the aspirin and placebo. And it would be the same. They will measure the time to exhaustion besides the increasing in body temperature, and their target to reach 60 candidates. So far, they have 36, and they are doing very well in the initial results. One of the interesting things I found is the paramagnetic REM lesion in the multiple sclerosis. Last year in German Neurology, they published the relationship between the paramagnetic REM lesion and the disability with MS. And they found MS patients that they have 4 or more paramagnetic REM lesions, they showed higher disability and cognitive decline even if they are young in their age. This study, which they released the initial results in ECTRIMS of this year, studies that if this REM lesion, and maybe I can introduce a little about it. If you can see it, it is on a special sequence in the MRI called the SWI, susceptibility weighted images, or the T2 star. And this sequence is very famous to detect the hemosiderin for the chronic hemorrhages and examples. So this lesion, it shows that an isotense on the SWI surrounded by hypotense area is called the REM, the RIM. So they studied this lesion, how's the sensitivity and specificity for MS to differentiating from the other demyelinating diseases. And it showed that sensitivity of this lesion, the paramagnetic lesions or the PRLs, 52%, they were in 52% compared to 7% for non-MS diseases like HIV, like the sarcoid, the SUSAC, and the HTLV and tropical spastic paraparesis, which raising the specificity for that up to 93%. Another lesions, which is the perivenular or the central vein sign, they looked at also in the MS population in this study compared to the non-MS demyelinating diseases, and they found that for the perivenular lesions in 96% in MS populations compared to the 4% to the old panel of the disease, including and if you can see from this diagram, that NMOS disorder having some of the perivenular lesions and the SUSAC. For the PRLs, SUSAC was the only disease that showed high prominence in the numbers compared to the others, but it didn't reach the same as the multiple sclerosis. Combining both together, and this is very important even in the dissemination in space criteria, McDonald's, the 2017. So adding both together in the last diagram on the right side, you can see MS itself with the combined together more than 40% of perivenular lesions plus the paramagnetic REM lesions, they contribute with specificity to more than 8%. Compared to the others, they didn't reach that specificity. However, there's only one patient that from the HTLV, the spastic paraparesis, the tropical spastic paraparesis, was only one patient that had the combination of the 40% of the perivenular along with the PRL's numbers. So to conclude with that is that those lesions, besides that it is associated with disability, and 4 lesions or more can lead to more disability and more cognitive decline even in a young age, this can be another modality or another step that help us in differentiating the MS from the other demyelinating disease. Maybe people that like last year there was a poster or initial results for a study that they extended the dosing of the natalizumab from every 4 weeks up to 6 weeks, and there was no any difference in the clinical activity. This year, this poster had been from an Italian group. They focused more on the radiological activity and divided two groups, either with the standard and intermittent dosing or the extended intermittent dosing with median of 6 weeks, and the standard with median of 4.5 weeks. And from this results, comparing the 6 and the 12 month, after the 2 years of natalizumab infusions, there was no any statistically significance for radiological activity between both groups. And this is reassuring results that besides the clinical activity, we can move forward and we don't have that much concerns about the radiological activity in natalizumab groups with the extended dosing, especially nowadays with the COVID time. Patients, they might have faced difficulty if we're going to a lockdown or the number of cases are picking up. So we need to move the patients maybe 6 weeks, maybe not exceeding 8 weeks, 7 weeks, or 8 weeks as maximum. This would be comfortable for them. Moving to the side effects, to the hematological side effects of the medications, lymphopenia, and maybe this is a very interesting poster, and I would like to hear also from my colleagues their experience about that. So we know that lymphopenia is one of the side effects for dimethyl fumarate with the Tecfidera and the fingolimod, the gelenia. However, both of them have different mechanism of actions. And reaching to a stage 4 or grade 4 of lymphopenia for fingolimod, it's not really worrying us. However, if we reach this with the dimethyl fumarate, now we start to have some panicking at nights and thinking more about this patient. So for this group, for the dimethyl fumarate, for more than 470 patients, only 27% of them, they had lower lymphocyte count less than 0.5, like a stage 3. 15 of those they had only for less than 6 months, and among those 15, after one month, they just repeat the labs. After 1 month, it backs more than it backs to grade 2. But for the 12 that they had lower lymphocyte count, less than 0.5, for more than 6 months, they divided those 12 between people that they continued on the dimethyl fumarate for a couple of months to notice if there is any difference, or they continued on the reduced dose for the dimethyl fumarate, or they stopped it completely and switched to alternative medication. Those who continued on a reduced dose on the dimethyl fumarate, and I think this is a tip that some of the neurologists that they do it with the fingolimod, that they do alternative dosing for a month or a couple of weeks, and once the lymphocytes start to pick up, so then we move to the regular dose. However, this doesn't seem to working with the dimethyl fumarate. For the other group, for the fingolimod, it was 169 patients, and they had 16 patients, which 6 among them, after 1 month, the lymphocytes back to more than 0.2. However, the remaining 10, when they continued on a reduced dose, the lymphocytes didn't pick up, and this was like around 6 numbers. 3 of them, they moved to another alternatives medications, and just 1 had stopped the fingolimod. So the time that, and I think this is a very important point, the time that the lymphocytes can pick up either with the dimethyl fumarate or with the fingolimod, it was around 90 days, around mean of 90 days for the dimethyl, for the fingolimod, and more than 115 days as a mean for the dimethyl fumarate. So it seems it takes longer time for the dimethyl fumarate compared with the fingolimod. However, some of those patients, they kept the authors, they kept those patients that they stayed longer with the low lymphocytes. They kept them on injectables till the lymphocytes start to pick up. And I think this is maybe one of the ways that the neurologists can overcome the rebound phenomena, especially with the fingolimod more than dimethyl fumarate. And maybe alternatively, some of the neurologists, they give monthly steroid till the lymphocytes start to pick up, just to avoid any rebound phenomena. However, I have a couple of patients that their lymphocytes remains low, maybe 0.3 or 0.4 with the dimethyl fumarate, and they didn't have any disease activity for a year. However, the lymphocytes didn't pick up. So I left them with no medications, just follow them up clinically, radiologically, and they remain disease-free up to a year for now. Another hematological problem with the cladribine, and we know cladribine can cause lymphopenia. However, from the pivotal trial that we have, the Clarity and the Clarity extension, the percentage was more than the numbers we are having here. It reached maybe 40% with the Clarity cladribine dosage compared to the placebo and the cladribine, and also for the Clarity extension. For this group, we have around 236 patients, and we compared they followed up the absolute lymphocyte count at month 3 after the cladribine and at month 7. And if you can see here that the majority of them, they had grade 1 and grade 2 lymphopenia, which means grade 1, it's lower than the lower normal for the lymphocytes, grade 2 from 0.8 to 0.5, grade 3 from 0.5 to 2, and grade 4 if it's less than 0.2. They didn't have in this study any grade 4 for the first 3 months. However, they had only one patient in each grade, which is around 0.5% at month 7. So with the total of this, the total number of these patients, it was very surprising for me that they didn't delay any of the dosing for patients for the second cycle due to grade 4 lymphopenia. However, as we mentioned that there were like only 2 patients with grade 3 or grade 4, so there was not a lot of patients with the initial dosage. However, they didn't have any grade 4 lymphopenia at month 15, and at month 24, they had only 11%, which is 1 patient out of the 9. And none of the patients and those that have grade 3 or grade 4 had an infections. The infections, they were all in the majority of grade 1 and grade 2, and it didn't differ from the pivotal trials. They had some of the pneumonia, tooth abscess, VZV reinfection or infection, or candidiasis. Another interesting part or hematological abnormalities with the medications is the neutropenia with the ocrelizumab. And we know that there was not a lot of reported cases, especially with the pivotal trial with the neutrophils. However, there were, in the real practice, there were 2 maybe cases reported with the neutropenia with the ocrelizumab. This poster, they presented a case series of 3 patients. One of them had, after more than 100 days of initial Ocrevus, they had neutrophils of 0. So they had neutropenia, they had an infection, lymphadenopathy, and they were treated with antibiotic courses and granulate stimulating, colony stimulating factors, couple of dosage, and he had recurrent neutropenia with recurrent admissions and antibiotics, and then he was treated and continued in the medications without any further neutropenic attacks. Another patient that also he had this starting around more than 100 days after the initial dosage, and he had also neutropenic attacks a couple of times, treated with antibiotics with the granulocyte colony stimulating factors, and the patient improved after that, and he didn't get any further. And he showed disease stability clinically and radiologically. The third patient, he had the same with a lot of disease activity, and he moved after being treating to the hematological autological stem cells. Neutralizing antibodies indication for medication failure. We know alemtuzumab, it's an anti-CD52, and despite that it is a human monoclonal, if we look into the neutralizing antibodies for this medication, it is higher than the other medications compared to the natalizumab, which is 5 to 9%, compared to the ocrelizumab, it's less than 1%, and for the rituximab, it's 1 to 4%. So the 85% of the alemtuzumab, they might have neutralizing antibodies and indicating a medication failure. For this patient, for this case report, the patient started the in 2015 the first cycle of alemtuzumab, and as you see in the graph, that it was it showed depletion for the lymphocyte, and he had the second cycle in 2016, and also it was depleted. However, in 2018, the patient had radiological and clinical activity in the brain and the spinal cord, and he got the third cycle of the alemtuzumab. However, he continued to relapse. So after treating the patient with the steroids and the plasmapheresis, they thought that maybe the patient had a neutralizing antibodies or anti-drug antibodies, and they checked that with the quantitative methods, and it showed that he has an anti-drug antibodies and also with the neutralizing antibodies, as you see on the right side graph, so indicating that neutralizing antibodies and anti-drug antibodies can be an indication of alemtuzumab failure. And I'm sure a lot of us have a patient that they start them with a big gun, it's clinically indicated, and how alemtuzumab doesn't work. But I'm not sure how many % of you in your practice think about the antibodies as an indication for the failure. The acapella study, they looked into the hypogammaglobulinemia and GC virus status in patients treated with ocrelizumab as an indication. In the pivotal trial, all those patients that they have low level of IgG, they excluded from the study. And we don't know exactly if what is the effect of the Ocrevus or anti-CD20 on the GC virus. We feel safe to start the patients if they have the GC virus on the BCL depletion, that it might not causing PML like the other medications. However, it's not guaranteed if the patient had previous medications and high GC virus. So they screened the hypogammaglobulinemia in patients with ocrelizumab, and there was a couple of patients that they had already low IgG as a baseline before starting the ocrelizumab, and they continue to have a low baseline, a low IgG, but not lower than their baseline. And as you see from the effect on the GC virus, comparing with the cycle 5 compared to the baseline, that the GC virus titers were going down with the ocrelizumab. So it means in assuring that even people with low IgG, they were not susceptible for more infections, and the GC virus titers are going down with the ocrelizumab. Ofatumumab, which came approved this year for the relapsing remitting multiple sclerosis, it is sub-Q anti-CD20, joining the anti-CD20 group for treatment of multiple sclerosis. Maybe this is more convenient as sub-Q for the administrative. However, the efficacy might fit as a first or as second line. So in this poster, they took only for the aspergillosis trial, they were both patients naive and who they've been treated with other medications. This poster, they only present the data from the naive patients only. And when they compare it to teriflunomide, it showed that there was a reduction in the annual relapse rate by 50% in favoring the ofatumumab, and there was risk reduction around 38% to 46% at month 3 and month 6 with the delayed confirmed disability worsening. It seems the ofatumumab having a very favorable response on radiological activity more than the clinical part. And if you see from the results from the GAD-enhancing lesions, there was like a reduction more than 95%, and for the T2 lesions, 82% reduction, and for in year 1 and in year 2, 97%, which is a very high percentage. Going to the NIDA-3, if you see from the first year, it was almost 3-folds more than the teriflunomides in favoring the ofatumumab, and 14-folds favoring the ofatumumab compared to the teriflunomide. Side effects were comparable on both groups. However, if you can notice here, alopecia, and this was very interesting, alopecia were as side effects for efatumumab, although it is 5% compared to the flunomide, but was very interesting finding because the other anti-CD20s, including the rituximab, and even the rituximab had been used in a couple of the dermatological autoimmune disorders with alopecia and was successful. They didn't have any alopecia side effects, neither for the ocrelizumab. So this is very interesting side effects. However, the injection reactions and the infection risk of malignancies, there was no any red flags for that. 2 years ago, there was a study published called MIRROR. They only measured the radiological activity with the ofatumumab for placebo, comparing to the placebo effect. And it was showing very favorable results for the for ofatumumab comparing to the placebo. This is another study being done in Japan and Russian patients, and they compared also the ofatumumab compared to placebo. They randomized it to the dosage of the ofatumumab at day 1 and once weekly for 2 weeks, and then every 4 weeks. And the cutoff initial was 24 weeks and then 48 weeks, and then they moved to the extension. And the primary endpoint was the radiological activity, but then the second point was also the clinical activity. So if you can see here, I think this is the first one that this results compared to the flunomide for the scipulus, that it's 58% in the reduction compared to the placebo, and there with the teriflunomide was only 50%. Moving to the radiological activity, also it was favoring with the in general with the general group for the Japanese. For Russian, reduction was 93%, and it was really surprising that 100% of the Russian group, they didn't have any radiological activity. For safety profile, it was almost the same as the scipulus, except that there is also CIDP reported with the ofatumumab group, and also this is a very interesting part with along with the alopecia, because like it seems that there might have some autoimmune side effects from that, which need to be studied maybe later.
Dr. Shusha, please, 2 minutes.
Yeah, sure. So this slides is going more with Dr. Suzanne Habib presented. We know that interferon have been labeled as safe for pregnancy and lactation. We compared in this German cohort patients with the postpartum all over a year, where they were both on interferon and glutaminyl acetate. There was no much difference compared to the general populations with the side effects, neither between two groups. And for relapses, also there were, both groups were similar in the results, and around 14% relapse in the first 3 months postpartum compared to 7% with the glutaminyl acetate group. However, at month 6 and 12, both were similar. DISCO study, maybe you heard about it. It's the first official trial to study that if discontinuation of the disease-modifying therapies for MS patients is useful or not. They are still recruiting people, and you need to have to stop have to be on medications stable for 5 years clinically and radiologically for 3 years. Just to highlight that feniparatide, it's a highly selective BTK medication inhibitor, will be studied in 3 trials, 2 for relapsing remitting and 1 for primary progressive. The relapsing remittings against the teriflunomide, and for the primary progressive, this is the first trial that they will use ocrelizumab as comparable. Thank you very much for your attention. I'll be happy to take questions at the end.
Thank you very much, Dr. Shusha. It was very nice. I'm very much surprised about the effort was put to summarize and highlight such a huge congress with hundreds of presentation. Very good. Well done. Thank you very much.
Thank you.
So it's my time now. I think I will count for myself. Timing. My name is Mustafa Shakra. I'm a neurologist at Sheikh Khalifa Medical City. I will share my slides. So my talk today is about multiple sclerosis, the mimics. Nothing related, my disclosure for this. So just I'm starting with a clinical case that it is true. It's from my experience. The patient was 71-year-old female referred urgently to our clinic by an ENT surgeon for the diagnosis of multiple sclerosis. So what I understood from the patient that she suffered from acute vertigo attack about 1 week prior to be transferred to our clinic urgently. And she said that she had similar probably attack 2 years ago with again vertigo that resolved by itself. The issue that the ENT surgeon sent this lady to MRI and the radiologist gives this report, lesions are compatible with multiple sclerosis. So he read this one and referred her urgently to the neurology clinic. This was her MRI. And as you can see, there is small vessel disease, white matter, periventricular area, which is expected from the elderly. So elderly comes on the top of cases that are probably mimicking the multiple sclerosis. Why? Because usually they have white matter disease due to aging, due to other morbidities, atherosclerosis. Additionally, they are having some neurological symptoms and complaints related either to diabetic neuropathy, to prostatic complaints, visual impairment, carpal tunnel syndrome, and other complaints. So this mix of white matter disease and some neurological complaints put them at risk of being referred to wrongly to neurology clinic, usually as multiple sclerosis, as we did see in the last the case. So usually in the small vessel disease, there are some characteristics that put the radiological findings far away from the MS characteristic findings. Usually, carboscolism is not be affected radiologically by small vessel disease. U-fiber is the same also. Either infratentorial and the areas of infratentorial and spinal cord are hardly be affected by small vessel disease of elderly. Also, we don't find black holes. And usually what we find the lacunar infarction or this white matter, small white matter infarction. This is to the opposite of MS, where the corpusculosum is affected radiologically, and often there are some signals, radiological signals of U fibers and supratentorial, infratentorial, and the spinal cord. So when it comes to MS, regardless of the criteria we are using, the old one of 60s or the new one of last 2017, the fundamentals of this criteria are still dissemination in time and space, and there is no better explanation account for the symptom. This is always existing. There is no better explanation. So what are the better explanations? This is the list of that usually used to give other explanation for the neurological symptoms and radiological signs. So on the top of them, if you see the indicators here, age-related, we see a lot of migrainous ischemia or the non-specific white matter disease, CNS vasculitis. Hardly we see here in this area Behçet disease, or CNS lymphoma, Lyme disease. Also, again, it is extremely rare in the Middle East. CADASIL and sarcoidosis, CNS lupus. Anyway, from my experience, this comes either the migraine or age-related on the top of the other explanation, possible other explanation for the radiological findings and neurological symptoms. This is from one of the textbook that looked at this problem of mimics. They found that the most common reason for falsely attributing patient symptoms to multiple sclerosis is faulty interpretation of the magnetic resonance imaging. This is the same in our case that I presented. It was 71-year-old, came with vertigo, similar history before, and again, because of the false interpretation of the magnetic reason patient was referred to unrelated service. So what's the definition of red flags? It's the wrong sign of danger or a problem. It's in MS, it means that there is something in the history, in clinical examination, in investigation is not suggestive of multiple sclerosis. So there are a lot of red flags. There are consensus that was published in 2006, published 70 plus red flags, but this is when we are looking at the history and the clinical examination. Whenever we have a normal neurological examination, this might be a red flag. Sorry. This might be a red flag for diagnosis. Hardly to find a patient with multiple sclerosis with normal neurological examination. Yani at minimal, you find some hyperreflexia, some signs of upper motor neuron disease, something like that. Abnormalities in single location. Again, remember that there is dissemination in space, so at least you have to find some abnormality in at least 2 or 3 functional systems. Progressive from the onset, we have to think about degenerative disorders, onset either in early childhood or over the age of 50. Again, this is red flag. You have to seek more to find more information, dig more in the diagnosis. Also, if there is some psychiatric presentation, some systemic symptoms, fever, skin rash, arthritis, something like this. If there prominent family history, although there's some clusters in the multiple families for multiple sclerosis, but still, if there is strong family history, we have to think about different disorders. If there is the more gray matter symptoms, especially if dementia, seizures, aphasia, amnesia from early beginning. Again, if there is some peripheral symptoms like socks and gloves, like it's indicating for peripheral disease, peripheral neuropathies, vasculation, same. If there's sudden onset, because you know this is an inflammation and it takes time, in fact, to build the inflammation. Sudden onset, we have to look for ischemic or vascular pathology. Again, if there is lack of typical symptoms, which include optic neuritis, bladder dysfunction, Lermet sign. Again, if there is prolonged benign history, whenever you find prolonged benign history, don't say this is benign multiple sclerosis. Go and dig back to see if there is any alternative diagnosis. When it comes to paraclinical tests, normal MRI, of course, it's a big red flag. In fact, we used to hear from probably older generation of neurologists, there is some cases of multiple sclerosis with normal MRI. What do I know? That MRI is equal to autopsy in confirming the multiple sclerosis. Normal CSF, although majority of cases has positive oligoclonal bands, still few of cases are negative. Still, if you find picture is not compatible completely with multiple sclerosis and you get normal CSF, this is a red flag. Again, if you find abnormal blood test, especially for autoimmune or vasculitis pathologies, you have to think about other diagnoses. This study, in fact, looks at red flags and compare them with symptoms. And this study was, I think, was published in 2012. It was in St. Vincent Hospital in Dublin. They received 244 patients as referral for MS. So what they found, they looked at red flags, and they also looked at the presenting symptoms. And the symptoms were examined by 2 different consultants to be considered as typical for multiple sclerosis or atypical for multiple sclerosis. Like if the patient presented with stocks and gloves, and they will think this is not a typical presentation for MS, while if comes with symptoms visual blurring with ocular pain, this is typical symptoms for multiple sclerosis. So they consider this is a conclusion. In fact, what they found that if symptoms were atypical and there are many red flags, this is completely is not multiple sclerosis. And whenever the symptoms are typical, they found that there's minimal red flags, and again, the possibility of multiple sclerosis is higher. So they, in fact, this is the red flags that they use to look at their, according to the consensus published by International Advisory Committee about red flags, clinical and paraclinical. And they use these red flags, which are 70 something plus red flags, and they looked at them, all of them. Additionally, they looked at symptoms if they are typical and atypical. And as you can see here, whenever the presentation is coming with typical symptoms, again, so typical symptoms, in fact, was a strongly indicator for multiple sclerosis and giving a very high predictive value with sensitivity of 90%, with specificity almost 85%. When in fact there was no red flags, the sensitivity and the specificity were less to confirming the multiple sclerosis. Same when it comes atypical symptoms, they found that the predictive value to dismiss the diagnosis of MS was even also high. Although whenever the flag was present, the specificity and the sensitivity were less than. So considering symptoms is better than looking at only red flags. Presenting symptoms as typical, it has higher sensitivity and specificity, in addition to positive predictive value higher than considering only red flags. So their conclusion was atypical features at the presentation are more sensitive and specific and have higher predictive value than red flags to refute the diagnosis of MS or CIS. So this is the typical feature that is usually suggestive of MS when the onset between 15 and 50, when there is optic neuritis, myelitis, intranuclear ophthalmoplegia, brainstem syndrome, also paroxysmal symptoms. There is history of Lermet sign. There is excessive unexplained fatigue and Utah phenomenon, as was talked already by Dr. Shusha. Now, when it comes about presentation, a specific presentation, optic neuritis, what is typical in optic neuritis and multiple sclerosis is unilateral. There is pain with ocular movement, and there is partial and central vision blurring, and usually there is normal disc or mild disc swelling. This is very typical presentation for optic neuritis in multiple sclerosis. What is atypical in multiple sclerosis to present bilateral optic neuritis? If there is no pain at all, if there is no light perception, if there is persistent or complete vision loss, if there is progressive optic neuropathy or neuroretinitis or uveitis. Recently, I received a patient from a colleague in ophthalmology because of uveitis to rule out the multiple sclerosis. This is not part of this is very atypical presentation in multiple sclerosis. Now, talking about brainstem symptoms, what is typical in multiple sclerosis is getting bilateral INO or INO if there is ataxia, if there is multiple directional nystagmus, facial numbness, sixth nerve palsy, vertigo, trigeminal pain, also very typical for multiple sclerosis. What is atypical and has to be considered as red flag whenever you get complete external ophthalmoplegia, if there is vertical gaze pulses, if there is some vascular territory syndrome. At this time you have to consider this is vascular pathology. If there is third nerve palsy, if there is progressive trigeminal sensory neuropathy, also focal dystonia, torticollis, this is not part of multiple sclerosis. So this is very atypical presentation. For myelitis, it is usually partial myelopathy. It's not complete. There is also associated Lermet symptom. There is some numbness, urinary urgency and incontinence, and there is some, if there is especially for a primary progressive multiple sclerosis, probably will see a primary progressive spastic paraplegia. What is atypical, if you get some vascular territory, especially that is compatible with anterior spinal artery, if you get quadricuana syndrome, if there is a sharp sensory level to all modalities on the localized spinal pain or radicular pain. Radicular pain is not part of MS. A complete Brown-Sequard syndrome, acute urinary retention, progressive sensory ataxia. This is not very much typical for MS. This is red flag. Should look for another differential diagnosis. When it comes to radiology, there is very much information in this, in addition to what mentioned by the update by Dr. Shusha, which is very interesting, in fact. This is a usually classic characteristic of MS lesions when it comes to MRI in subtentorial or infratentorial, juxtacortical, you fiber involvement, periventricular corpus callosum, and even the cortical lesions here on 3D FLAIR or DIR. Now, because you can find another or lesions that are more specific for MS, considering the location, the morphology. Here, you usual lesions with sharp margin. It has oval shape. It is usually periventricular, like Dawson finger, bilateral in the bilateral hemisphere. There is some asymmetric. And if we go to signal intensity, it is intermediate to low. The intensity at the T1, it is hyper intense in T2. There is also black holes. Don't forget black holes. Black holes doesn't exist in majority of other diseases. This is almost very specific to multiple sclerosis. Enhancement, it goes for nodular or homogeneous or ring-like. It's not complete ring. When it comes to optic nerve, there is hyperintensity you find on a stair. And when it's spinal, also when it comes for spinal cord, again, it is short segment. This is in contradictory to neuromyelitis optica. This is an example of multiple lesions that are compatible with multiple sclerosis and different gradients, as you can see in T1, T1-2 with enhancement and multiple locations. Now, there are some also MRI clues to misdiagnose MS in the brain and the spine. Whenever in the brain you find small lesions less than 3 millimeters, this is probably is not multiple sclerosis lesions. Usually the lesion is more than 5 millimeters. If it is internal capsule, it's only prominent in infratentorial area and nothing in supratentorial area. Is only prominent in a gray matter involvement in basal ganglia. If this is very confluent, hemispheric, if there is associated hydrocephalus or enlargement of ventricles, if there is severe or brainstem or cerebellar atrophies, that indicates probably for degenerative disorder, if the callosum is not involved at all. So this is red flags, radiological red flags that indicating that the diagnosis of MS is in doubt, and you have to find out different or look for different diagnoses. When it comes to the spine, if there is, of course, a large segment, more than two segments of vertebral segments, if there is severe swelling, if there is leptomeningeal enhancement, and if there is T1 hypointensity lesions, this is red flags for the diagnosis of MS, and we have to look for different diagnoses. In CSF, it's, you know, the typical finding in MS, you find the higher level of immunoglobulin and or immunoglobulin index and oligoclonal bands. And this is oligoclonal bands usually is positive almost in 90 or more than 90%. And while the IgG index is almost more than 70%. What is atypical to find absence of oligoclonal band or normal IgG index, to find even cell count more than 50%, is you have, there is doubt about the diagnosis, and if there is very high protein level in CSF. So how common this, is it common? This study, in fact, was done in two academic centers in the States, and they look at the referral for MS, and what they found, in fact, that the misdiagnosis is common. There, in this cohort, which included two academic centers, they found almost 20% of patients were carried, in fact, the diagnosis that is not fulfilling the diagnosis of MS, multiple sclerosis, according to McDonald criteria, and it's likely an alternative diagnosis. What they found more interesting is, if you see here, that the most strong misdiagnosis was made by neurologists, in fact, in both academic centers, CIDRAS and UCLA, and both of them, more than 75% of cases, they were of wrong diagnosis among the referral were made by neurologists. And if you see that it took for some patient up to 4 years to get the correct diagnosis. And personally, I have patients who had been using fingolimod for almost 9 years or 10 years before the diagnosis was confirmed that it is not multiple sclerosis. Again, if there is a clinical syndrome atypical of MS, atypical symptoms of MS were even in majority of referrals, yet the diagnosis was made as multiple sclerosis. So radiological red flag were existing almost in 80 and more than 80 of cases that were diagnosed as MS. So it's very, very common. In fact, it's not even, it can be happening even by neurologists, experienced neurologists. Sometimes even they are going to consider multiple sclerosis in patients that, in fact, having few of red flags, they don't notice this. And because of this, it's better just to revisit diagnosis, probably with every visit. On the top of the mimics or the other diagnosis were migraine as expected. In the past 5 years, we have to stop the DMDs in almost 3 of our patients because they were, in fact, misdiagnosed. The clinical presentation was completely migraine, and the finding, as you know, this is white matter abnormalities or dots that is very common in migraine sometimes. This has, in fact, a lot of consequences, especially in where in some countries their doctors are sued or get malpractice claims. And as you can see here, many cases, if you look at the internet, or you'll find hundreds of these cases in the Western countries are looking for doctors and their mistake, and they get by the end to the court with a lot of compensations. Now, this is from our region, from the Middle East, the Security Group and the EUB, and they looked, in fact, about alternative diagnosis in patients referred to specialized centers, one in the Kuwait and the other one in EUB in Lebanon. And what they found that it is very positive, predictive for the diagnosis, for the final diagnosis of multiple sclerosis was age, was in fact multiple functional system symptoms, and the family history of systemic disorders, and the enhancement lesion in the brain, periventricular and oligoclonal bands. What in fact was against the diagnosis, in fact, was the family history of MS doesn't in fact support the diagnosis of MS. It is negative predictive factor for diagnosis of MS. And the other one was presenting with only sensory symptoms. So is there a way to prevent the misdiagnosis? I think we get, if we go and follow carefully the diagnostic criteria and in patients with specific, especially clinical syndromes, and it gave with very hard, you have to find objective, in fact, neurological findings in a clinical exam. So this is, in fact, the most probably important way to protect or prevent the misdiagnosis. Avoid depending on imaging only, especially if you have a clinical, very atypical clinical presentation. You have to look every time for red flags and every visit in any patient, especially the patient who are showing very benign course of the disease. If again you have to evaluate the CSF fluids for oligoclonal bands, and this way, in fact, give some, in fact, comfortability in making decision of the diagnosis or excluding the diagnosis. In some case, you just have to wait and see, and to look again, and to follow patient closely to decide, especially if the symptoms were not clear and the MRI or CSF finding were equivocal. So my conclusion, misdiagnosis of multiple sclerosis is still common, as we saw in the academic center. Instead, 20% of cases were referred were in fact misdiagnosed as multiple sclerosis. It's much higher in patients who referred because of radiological suspicion. Lack of vigilance for the red flag is an important contributor. The strongest predictors for the final diagnosis for multiple sclerosis were in fact young age, presence of oligoclonal bands in CSF, and multiple very specific radiological findings. Thank you very much. I think I am in time. Start with myself. I will ask Suzanne. Is Suzanne around?
Yes, I am. I'm here.
So thank you, Suzanne. Thank you very much for your presentation. My question again about the IVF. We are getting referrals every for many patients about the prior to IVF, and we don't know exactly if there is different types of this type of pregnancy. I don't know in the words induction as multiple different type of hormones used. So how usually approach such cases, and what information you ask for prior to give your decision about approval or disapproval or IVF procedures?
Thank you for the question. First of all, before a lady goes for any kind of induction, I have to make sure that her disease course is stabilized. So this is number one, because if we're going to give her hormones, of course we have still we have to worry about any kind of relapses in her condition. So if she's disease stabilized, that would be fine. Of course, we have to consider what type of medication she is on. I mean, for the disease modifying therapy. As for the procedure itself, it has been decided, of course, by her gynecologist. And what we know that I'm not quite sure, I'm not quite aware about different types of IVF that's being used. But as I mentioned, that using gonadotropin agonists give deleterious effect, while using antagonists can be safer and can be used. This is advice I should give to gynecologist if they're undergoing hormone induction or IVF.
Okay, thank you very much. Another question now. The question by Dr. Nawal, she said, is sexual competence the important reason for infertility?
Yes, actually, dry orgasm or dry ejaculation, I think her question was specifically in males. So dry orgasm or dry ejaculation was reported in more than 70% of men with MS.
Okay, so yes, another question, I think, about if patient with MS becomes pregnant, it will be at risk for the baby and the mother. Is MS is a risk for mother and pregnant mother and baby?
If you're asking about pregnancy for MS patients, we know now from the studies that MS caused during the pregnancy, we have no increased risk, especially in the second and the third trimester. Probably in the first trimester, yes, but the second and third trimester, the risk is quite less, and people might be quite immune during this period. But considering this, we also have around 30% might have a relapse after delivery. If you're asking about the risk of transmitting the disease to the baby, there is no risk of transmitting the disease to the baby. There is no genetic transmission. There is no vertical transmission from the mother to the baby.
Okay, thank you very much. Again, another question, I think for Dr. Shusha. What is the reason of anemia in multiple sclerosis? This was, in fact, in first few slides of Dr. as prodrome. I think he talked about a prodrome of anemia and fatigue. And is Dr. Shusha around?
Yes, I am here. I hear the question.
So this is the question, Dr. Shusha. What is the reason for anemia in multiple sclerosis?
Yeah, sure. So what is the reason for the anemia? We don't know, but what I can comment on that, what is the role of anemia for an MS? So a lot of studies that shown that part of the MS lesions in the brain, it showed that iron load, and it showed iron-laden macrophages. So in part of the inflammatory cells in the brain, it combined with iron. So there is some iron deposition in the MS lesions and multiple sclerosis patients. And this was evident not only by the pathology, but even the sign that I showed on the MRI, the paramagnetic REM. This REM, it's hypotense on the SWI, and this is showed that there is a component of hemosiderin deposited with this, along with the macrophages and inflammatory cells. So maybe patients they present with anemia because like they have low iron that have been deposited in the brain as a part of the MS lesions.
Okay, but as you know, iron deposition in the brain is part of the degenerative process. It's not necessarily that there is associated anemia. It is very minimal amount of iron that doesn't explain anemia. I think I don't find any correlation, but I think anemia itself probably put patients at risk for multiple sclerosis, regardless of the reason of anemia. I don't know if I'm right.
Yeah, for the prodrome study, there were different types of anemia. Some of them they were iron deficiency anemia. Some of them they were autoimmune hemolytic anemia. Some of them they're related to the vitamin B12. And I agree with you. All of them can be an association or can be component of the MS itself. But I agree with you. Iron can be part of the neurodegenerative, but as you know that we have different types, different pathology in the MS lesions. So the chronic active lesion, it might carry part of the neurodegenerative component plus the active component. So they have the iron deposition, but at the same time, they have an active lesion, the active inflammatory cells, like the macrophage-laden, it's component with the iron. It's called iron-laden macrophages. But it can be association part with the vitamin B12 deficiency. We know it's a known factor that can lead to the demyelination, or part of the autoimmune diseases like the autoimmune hemolytic anemia as well.
One question by me. In fact, I attended a few lectures about, in fact, this prodrome and how we can probably go and start treatment as early as possible. One of the lectures were looked, in fact, about the Epstein-Barr virus and consider this population is at higher risk for developing multiple sclerosis in the future. And they are trying, in fact, to collect this patient group of people very early and try probably to start some type of a preventive treatment. Do you have any comment about this? Because we used, in fact, to make blood test exams for Epstein-Barr virus before we went into the insurance issues. Now with insurance, it's hard to order Epstein virus antibodies. Our group before like 2000 or 2005, we were almost all are positive. Now, in fact, the same replication of data I see in the Congress, and I don't know if you have any comment about this.
Yeah, sure. So I would divide this into two parts. The first part about screening those patients and starting the medications. With the part of the prodrome that those manifestations, they might come after the radiological isolated syndrome, but the patient will not be caught earlier for that. And they didn't go into details of those patients if they have correlation with the lesions or not. But I agree with you, this prodrome can be an intermediate stage between the radiological isolated syndrome and the first demyelinating event. So but in the future, this was like an initial study, but I agree, like in the future, we might focus on those types of symptoms. If the patient having frequent visits to the health practitioner, the general health practitioner, or to the internist with the fatigue, the anemia, and pain, frequent visits, and more than the health control. So then maybe we can look into the imaging for these patients. For the second part, for the Epstein-Barr virus, yes, last year in the ECTRIMS of 2019, we published a study that including 1,000 patients, and it showed that more than 900 of those patients, they had an Epstein-Barr virus positive, and they screen as well the cytomegalovirus. So I agree with you, Epstein-Barr virus has a pertinent relationship with the multiple sclerosis, and it's the opposite with the cytomegalovirus. So if the patient has a cytomegalovirus, it seems that it's protective from the MS. But almost all the patients that we have the MS, when they screen them, they had an infection, a previous infection or evidence of the Epstein-Barr virus.
Thank you very much. Another question related to hot weather, and if aspirin works or helps in this, especially in this part of the world.
Yeah, sure. So we know that part of the component for the fatigue for MS patient is that the heat and the humidity, especially in our region. So the idea by using the aspirin is that the aspirin acts as an antipyretic. So it lowers the body core temperature, and at the same time, with its effect as an antipyretic, it prevents the increasing the resistance to the heat for the body. So if we use it, it reaches the peak within an hour. So if we use it an hour before the exercise or going to a longer trip or going for a walk in the hot weather, so it seems that it works. Adding to that as an alternative evidence that a lot of patients, they use a cooling methods for the exercise. They have a special jackets, they put dry ice inside the jackets, and then it seems that's working for them. It decreases the body temperature and it helps them compete the fatigue and delay the TOFS phenomenon. There was a study published maybe in 2006 or 7 that the patients with multiple sclerosis that they have premenstrual pseudo relapses, and as we know, during this time of the cycle, that the body temperature increased. So when they use the aspirin, it showed that it is effective during the initial part of the cycle, but not with the luteal phase. So this also giving a more assuring data that aspirin might work with its antibiotic effect.
Thank you very much. Very good. So one question for me, is there any coexistence of multiple sclerosis with psychiatric disorders? There are, in fact, coexistence between multiple sclerosis and psychiatric disorders. We ran a study in our institute a few years ago about psychiatric feature or psychiatric disorders among our group of multiple sclerosis. We found that there's almost like a good percentage of patients are having either a depression or in fact an anxiety disorders. And we have one in our group who had psychosis, in fact. So it might be coexisting. Again, the population of MS people probably as other population, they will have probably similar, they have similar exposure to get the diseases, psychiatric disease. But in our group, I think probably multiple sclerosis as a chronic disease put some, as other chronic diseases can probably increase the possibility of getting especially depression disorders. This was very prominent in our group of patients. The disease, now question for Dr. Suzanne about vulvodynia, if it is considered as part of MS. Dr. Suzanne?
Yeah, yes, sorry, I don't know.
Okay, you don't know.
Yes. No.
I think it's part
yes,
probably of sexual dysfunction during marriage. Yeah.
Okay. It is the main pain that a female with multiple sclerosis can experience is the dyspareunia due to dryness. But vulvodynia is also reported in patients with MS. But of course, it should not be like if the lady got vulvodynia, that means it could be MS. But if she has MS, that could be related to her disease.
Okay, other question. What is the best? I think this is anonymous attendant. Okay, what is the best drug of choice for MS? I think the best drug is the drug that control the relapses and radiological findings and doesn't cause any disability with very minimal adverse events. Do you have any other opinions?
What's the
Dr.
question?
Shusha, what is the best drug of choice for multiple sclerosis?
Well, there's no best drug that we can't like choose one medication. I agree with you. It depends on the patient profile. We choose depends on the relapses, the patient, fertility, social status, the job, the radiological imaging, how the disability is. Sometimes we choose a small gun and it works very well. Sometimes we choose a big gun, but it didn't do the job. So
exactly.
I agree. It depends on the patient profile.
Yeah. Okay. So again, another question. This is pain of vulva again and diagnosis of MS by exclusion. Can you read, Suzanne, the question from your side, as this is pain of vulva in the diagnosis by exclusion, but I did not in fact understand. I did not find that it was highlighted about differential diagnosis of MS. Can you get can you read these?
Actually, I think I read the question. She's asking if we can put it as a differential for MS. This is what I mentioned. If the lady has MS and she had a vulvar pain or that a vulvodynia, that could be related to MS. But if a patient presented and she's not known to have MS as vulvodynia, I cannot say this is could be MS because it's not a common presentation of multiple sclerosis, definitely.
Okay, so another question about how often optic symptoms are associated with multiple sclerosis. I think optic neuritis is one of the classic presentation for multiple sclerosis. It is probably one of the most common presentation or typical presentation for multiple sclerosis. With getting the typical findings of unilateral with pain and other characteristics. So the question again, in ENT practice, a lot of patients are suffering from migraine-like symptoms. May multiple sclerosis like symptoms may be multiple sclerosis. So I think this is for me probably. In fact, migraine comes on the top of mimics for the top of the mimics for multiple sclerosis. In my practice for the past few years, we stopped the treatment in at least 3 patients, and recently there was a patient referred to my clinic again. She has typical migraine and she has very much typical MS. In fact, findings with even enhancement. So it represents, in fact, radiologically isolated syndrome, and we are following now this condition. So migraine itself, the pain, the migraine itself is not typical symptom of multiple sclerosis. Considering non-typical symptoms, it has high sensitivity and specificity to exclude or the diagnosis of multiple sclerosis, if only migraine or headache. And what is we have some other can consider that this as red flag for early symptom because of I don't this is for Suzanne, I think.
Let me read the question. Can
It
consider
is
this as a red flag for early symptoms for MS because the investigations for gynecologists is not to do MRI for those type of patients. I don't know. I think she referred to the same patient that she asked earlier about vulvodynia.
possibly, I'm not sure.
No, for vulvodynia, there are many causes. So we have to look for any kind of trauma or like after birth injuries, that can be the cause. But if the patient's showing other symptoms related to multiple sclerosis or classic of multiple sclerosis, definitely patient can be referred to neurologist for further investigations, of course, including MRI. I don't know if you got the question.
Okay, another question about why most complaints of men are impotence.
Impotence in male, because we said this is if you're referring to infertility because of erectile dysfunction, ejaculatory problems. This is the cause for impotence in male in MS. But if you're talking in general, I cannot answer this question, I think.
Okay, I see. So another question about typical prevalence of MS in the Middle East. I can answer this question. In fact. Now a few years ago we ran a prevalence and incidence study among Emirati in the Abu Dhabi, and what we found, in fact, the prevalence was 57 or around 57 or around 60 per 100,000 of population, which is almost equal to the prevalence in the south of Europe, like in Greece or some other areas. It is common. Now in the Middle East, it is far different. So in Iran, the prevalence is very high. In area like I think Sudan or Yemen, this is again it's very low. So there is no like one number to consider as the prevalence in the Middle East. I think it depending on the countries, there's different studies done, like in Kuwait, in Emirates, in Oman, in Qatar, and in Egypt, and in Saudi Arabia. There are good studies, so we can give number, but these numbers are not in fact equal to each other. What's your opinion, Suzanne?
Correct. I agree. So we don't have the exact number for that. Yeah.
Okay, this here question, what are the medications can use safely in pregnant? This is, I think, hot topic. What's your opinion now?
What kind of medicine? Is it medicine for treatment?
Safe for, yes, for
I understand.
MS.
Now, is it a treatment for the disease-modifying therapy or other drugs that can be used during pregnancy?
I think
So
she means because the talk about MS, so I think it is about the DMDs.
So there is no safe medication during pregnancy, first or late trimester, but we know that interferons in general are safe and can be continued during pregnancy if indicated. There is no harm, as well as we also have reports that our studies show that natalizumab can be safe in patients if they have high risk of relapse during pregnancy.
Mona asked about MS, asks Dr. Suzanne for again exercise and MS patients.
Very strongly encouraged to do exercise.
And if this is affecting, in fact, the sexual ability of the patients.
It does, because at least fatigue can improve with exercise, and fatigue is one of the symptoms that can also impede the sexual activities or the relationship.
Okay, wonderful. So what the impact of surgery on MS patients? I think, what's your opinion, Dr. Shusha? Is there any impact of surgery on MS patients?
Well, for the surgery itself, no, probably no.
Especially anesthesia.
Yes. Okay. For the anesthesia, there is no enough evidence that anesthesia can exacerbate the relapses. Not in the MS, but however, there are a couple of reports that with the bupivacaine, it can induce transverse myelitis.
Okay.
So when they use the bupivacaine in different patients, even patients that they didn't have any demyelinating disease, there are a couple of reports that the use of bupivacaine can induce transverse myelitis.
Okay. But generally speaking, I think it is safe to go to surgery and general anesthesia and multiple sclerosis patients. And
Yes.
usually we are receiving this clearance prior to any surgery. It is safe. What the risks, in fact, of anesthesia usually are related to lung disease and heart disease. It's not directly correlated with MS. Okay, so usually yes, surgeries and anesthesia are safe during pregnancy. A question for Suzanne again about the probability of getting twins in patients with MS comparing with other non-MS people.
It depends, because if we say for induced fertilization or artificial fertilization, definitely the risk of getting twins or the probability of getting twins is more. But in fact, and honestly, I didn't go through any articles that compare having twins in MS as compared to non-MS patient individuals.
Dr. Shusha, how many hours should we start the exercise after taking aspirin?
So we take the aspirin an hour before the exercise.
I will give you this question, Dr. Shusha, about stem cell therapy in multiple sclerosis. Because you are from Canada, okay? I know there is there is
Sure.
good studies there. Okay, please.
So there are different types of stem cell studies, either the autologous or the mesenchymal stem cells. Not all the centers are now running this studies. In Canada, only Ottawa that they are running these studies, and they choose specific patients or a special type of patients if they have a very aggressive disease, and all the higher efficacy medications failed. It's not an easy procedure because, like, patients, they need to go to a preparatory steps prior the stem cells. They need to be put on cyclophosphamide, and we know the effect of the fertility of cyclophosphamide on fertility. So we have to explain the patient all the process about that, and that they might get affected for that. However, for the outcomes, it has a great outcomes, not only for MS, for the NMO, had a lot of patients that they were EDSS of 7, they were on wheelchairs, and now they're back to EDSS of 5 or 4.5. So it's not one type, and I think this is good. This is a good question because, like, a lot of the patients in the regions, they just go and follow the ads for China, for India, are doing stem cells, and they don't know what they are doing there. They might take the stem cells from the patient himself, and they just inject it as a trial, and they are not following the protocol. And a lot of patients actually they gotten worse when they come back from China or India. So and for the time being, unfortunately, Ottawa, they don't run any of those stem cells on the patients outside Canada. But I think we might consider this in the future.
Thank you very much. I think the only country that give approval for stem cell transplantation is Scotland. Unfortunately, there is no stem cell center in Scotland, so they have to send patients somewhere. Okay, now the question I think here for me about unilateral trigeminal pain, is it typical or atypical for it? It is typical for it. It is relatively common among patients with multiple sclerosis to suffer from unilateral trigeminal pain. Can ischemic attack of sudden loss of vision and return within half an hour is considered as early red flag of MS? Certainly. Usually the attack of MS is an inflammatory attack. It takes time to give the complete symptoms or syndrome. It doesn't happen like ischemic attacks all of a sudden in same second. No, it takes time to develop. So the multiple sclerosis is an inflammatory process, need inflammation to build and give symptoms, while the ischemic, in fact, attacks are related to sudden hypoperfusion, sudden onset of focal motor or focal neurological deficit due to hypoperfusion or blockade of perfusion of the blood. And so this is yes here. Are there any medication that cause, okay, this is for Suzanne, any medication that we are using in MS can give baby abnormality or teratogenicity for the baby?
Many medications used as disease-modifying therapy or immunosuppressive can cause teratogenicity in MS with different degrees. But usually we ask women who intend to get pregnant, she has to stop her medication before getting pregnant at least 2 months. And it's variable for different types of agents. As we mentioned, that there are only 2 medicines that can be used safely during pregnancy, and this is namely interferons and Copaxone, glatiramer acetate, that are not teratogenic, and they are safe and can be used during pregnancy. Otherwise, we can consider them all can cause some degree of
I think
repetition.
even they are probably considering the symptomatic therapies that we are using sometimes in
Definitely.
Okay.
Definitely, yes. Yeah.
Okay, there is a question now for I think, okay. There is a question about fingolimod stopping after 7 years of being relapse-free. Dr. Shusha, do you
Sure.
stop fingolimod after being relapse-free for 7 years?
So we can tackle this from different points or from multi-points. First of all, how old is the patient? Is the patient in his 50s? So then, and it had been stable for 7 years, but now the patient in her 50s. So then I would be worried more about the infection rather than the disease, because we know the disease fades out after the age of 50. So the patient had been stable for 7 years, but she's over 50, and she doesn't have any progressive disability. Her EDSS is stable, and her radiological imaging is stable at least for 3 years, and no clinical relapses. So then I might phase her out with this medication precautiously, considering the risk of infection more than the risk of the disease, because we know with the fingolimod after the age of 50, so it's a risk for the PML. So if the lymphocytes are very low, and she's over 50, had been stable, so then yes, I phase her out. But if the patient is young and she's stable for 7 years and lymphocytes is accepted, so I don't see any reasons to stop the medication.
Okay, thank you. Any opinion, Dr. Suzanne?
I would agree with Dr. Shusha, what he has mentioned. Yes.
Do you consider 7 years is enough to stop the medication in a young person?
It depends. It depends on how the course of the disease was behaving during the 7 years. But definitely, if the patient reach a stage that there is no relapses and there is no indication of progression, I would consider stopping the course of the drugs.
Okay. There is question about best diet for patient with multiple sclerosis and paraplegia. I doubt there is any diet even related to MS. What we are recommending in diet is a healthy diet that is generic for everybody, for me, for Dr. Suzanne, for Dr. Shusha, for any patient of MS. So healthy diet is good for everybody. No specific diet for multiple sclerosis.
Sure.
MS and mood disorder, and I think I answered this. Mood disorders are common, almost double the fold in among the patients with MS in comparison with general population. Vitamin D deficiency is a main predisposing factor in the Middle East. Is it right, Dr. Suzanne?
Yes, it is. Not specific in the Middle East, but in general, the recent studies have shown that multiple deficiency of vitamin D, one of the main risk factors for getting MS.
Okay, is it the same in Canada, Dr. Shusha?
Yes, absolutely. And actually, it was surprising that we have low vitamin D in our region, despite that the sun is all the time, is there all the time. But I think because of the prolonged working hours, we get out of house like in the early morning, maybe 6:30, and then we get out back to home. It's already the sunset time, so we don't get enough exposure.
Okay.
Myself, I take the 50,000 tablet once weekly.
Okay.
Yeah.
There is a question for Dr. Shusha about Bubi vaccine producing neuritis. I don't know about this.
Maybe the bupivacaine, the anesthetic.
Bupivacaine, yes, bupivacaine, sorry. Inducing, bupivacaine, the question about the anesthesia.
Oh yeah, no, it's not inducing neuritis. There are a couple of reports that the intrathecal bupivacaine induced transverse myelitis.
Yes.
Not optic neuritis. It had been reported even for orthopedic operations. Patients when they had the bupivacaine, and 2 patients actually in 2 different reports, when they had the bupivacaine as an intrathecal, A couple of days later, they developed weakness and they thought it's related to the procedure, but then they found that the patient had transverse myelitis. In NMO patients, a couple of the reports, when they have the bupivacaine as an aesthetic material, they have a big relapse after that.
Wonderful. I think this is very known even among population outside of normal population. Some types of even lumbar or lumbar anesthesia can cause transverse myelitis, and there was many studies looking at the possible mechanism of pathogenesis in these cases. So I think it is a rare complication, and it is not only among a population of multiple sclerosis, even it's among general population.
I agree with you.
Okay. There is a question about exercise during relapse. Dr. Suzanne?
Again, I say recommended, very much recommended, because relapse can be the weakness, and so weakness can be improved only by exercise.
Okay, do you recommend exercising during relapse?
Yes, yes,
Okay.
yes.
Okay.
Of course, they should not overdo it, because we don't need to increase the body heat, but
Yes,
exercise
certainly.
is recommended. Yeah.
This is again a question for Suzanne. Shall male patient now, or with multiple sclerosis and on medication like Tecfidera or other medication, stop the medication before trying to fathering a baby?
For male patients, it's not indicated that they should stop their medications, because we know that semen does not transmit what we say, the medicine, the drugs does not transfer to semen. But if we're talking about females, we're talking about women, because they can have their medicine through the placenta to the babies. So for the male patients, for Tecfidera or other medicines, no need to stop the medicine.
Okay, other question about collagen supplements to MS patient. Anyone has? I don't have any information about collagen supplements and to MS patient. I think this is probably supplements. It can be used in MS patient and other. It doesn't have. I don't expect it has any bad effect on MS. I don't know about Dr. Shusha and Dr. Suzanne.
It doesn't. They can use it safely. Yeah.
Okay.
Unless it is a filler.
Oh, it is a.
No, even for filler, it's no harm.
Now, there are a couple of reports that filler can induce the autoimmune and the autoimmune process and activate the demyelination. So Botox is fine, but for the fillers, it can induce the autoimmune system.
Okay. Okay. This is very new information.
And that's new to me. Oh, yeah.
Okay. So there is a question I did not understand about genotyping AC and AS. Do you know? This is Emmanuel is asking about my genotype is AC and my girlfriend is AS. Can we go ahead with a marriage? Of course, why not? What AC, what AS?
I don't know.
And he's asking again what the difference between AC and AS. So I don't know. So about do you advise to use IV vitamin D or only capsule for MS patients? Dr. Shusha?
I think the oral works very well for the patients. Okay. The recommended dose, what we are following for the MS patients, usually is 4,000 international unit per day in winter, and 2,000, or if there is no enough exposure, and 2,000 in summer.
Okay, I think we reached to the time of 10 o'clock. Still, we have few questions, but unfortunately, we have to conclude. I would like to ask to thank Dr. Suzanne, thank Dr. Shusha, thank even Novartis and MCO, and thank you all for attending and in fact making this event very successful. Thank you very much and good night.
Thank you very much.
Thank you.
Good night, everyone.
Good night, everyone. Bye-bye.
Bye.